Anaphylaxis awareness and treatment. What to do when someone has an allergic reaction. Is an allergy trigger known? If the trigger is known, you can assess measures to remove the trigger, which is remove the bee stinger, rinse mouth when allergens in the mouth, avoid drug if there's a drug reaction. Is the patient an allergy kid? The patient may have an EpiPen available, and you can assess if the patient has prior histories of severe allergic reaction and anaphylaxis. And never had allergic reactions before, you still treat similarly to patients with allergies. Anaphylaxis or not. Time is allergy. Just like how we are taught time is brain or muscle for strokes and MIs, for anaphylactic reactions, time is allergy. The longer it takes to administer treatment for anaphylaxis, the worse the prognosis. So you must clinically assess for anaphylaxis. Anaphylaxis is a clinical diagnosis with symptoms that occur along a continuum. Symptoms may be as mild as itching in the eyes, nose, or skin, although urticaria and tongue swelling manifest most commonly. Symptoms may progress rapidly to cardiovascular or respiratory collapse. So if there's a sudden onset of an illness within minutes to hours, and you have involved in the skin, mucosal tissue, or both such as hives, flushing, swollen lips, and at least one of the following respiratory symptoms or reduced blood pressure, you can consider anaphylaxis. Or if you have two of the following symptoms that occur suddenly after an exposure to a likely allergen or other trigger for that patient within minutes to hours, or if you have reduced blood pressure after exposure to a known allergen for that patient, you should consider anaphylaxis as a clinical signs. While the majority of the focus is placed on the above symptoms of respiratory, cutaneous, and hypotensive symptoms, it is important to understand and evaluate for any other signs of end organ damage from hypoperfusion. This may include abdominal pain and cramps, vomiting, hypotonia, syncope, or incontinence. GI symptoms are present in up to 30% of patients. While the loss of airway control due to laryngeal edema is a primary concern, one must not fail to recognize anaphylaxis in the patient who does not endorse upper airway edema or respiratory complaints. After you clinically suspect anaphylaxis, epinephrine is the treatment. Antihistamines may be helpful in treating cutaneous symptoms that persist following resolution of anaphylaxis symptoms, but they are not recommended until the acute reaction has been successfully treated with more appropriate interventions. Thinking back to time as allergy, antihistamines can blunt anaphylaxis symptoms, thus delay in treating anaphylaxis, so you do not want to give Benadryl. Unfortunately, antihistamine use is the most common reason providers report for not using epinephrine, leaving patients at increased risk for life-threatening sequelae. Literature supports that antihistamines have no effect on anaphylaxis. Antihistamine administration is optional, and use should be only for the symptomatic relief of pruritus and rash. Understanding that will take over an hour. Healthcare professionals often inappropriately rely on diphenhydramine for anaphylactic reactions. Intramuscular epinephrine has been well established as the first-line treatment for anaphylactic reactions and should be administered immediately upon the clinical suspicion. Epinephrine is the only pharmacotherapy that will treat the vasodilation and bronchoconstriction characteristics of anaphylaxis. EpiPen typically is dosed at 0.3 milligrams for adults and 0.15 for children and injected to the lateral thigh. The mnemonic is blue to the sky, orange to the thigh. A repeat dose can be administered in 5 minutes if rapid improvement is not seen. There is no evidence for the use of corticosteroids in the acute treatment of anaphylaxis. Steroids take 4 to 6 hours to reach maximum effectiveness. However, they may be beneficial in preventing biphasic reactions, which is when symptoms reoccur 6 to 10 hours later. Just to emphasize, like we are taught door to balloon time for MIs is important, so is STI to epi time for anaphylaxis. Delaying epi is associated with higher morbidity and mortality. Epinephrine is the only drug that targets the cardiovascular and respiratory systems. After diagnosis and treatment of anaphylaxis, good practice is that all patients should be kept under observation in a setting capable of managing anaphylaxis until symptoms have fully resolved. The main point is to not delay the administration of epinephrine for anaphylaxis. Biphasic anaphylaxis is a well-recognized potential complication of anaphylaxis and has been defined as recurrent anaphylaxis after complete improvement. This has been reported to occur between 1 to 78 hours after the onset of the initial anaphylactic reaction, and the treatment is the same as the initial phase. To address EpiPen use hesitancy, it's important to note that intramuscular injection is less likely to cause cardiovascular side effects. IV epi is more likely to do that. Only 1.3% of patients presented with cardiovascular adverse effects when epinephrine was administered via IM injection, and none of those were considered major. It is notable that the majority of serious cardiovascular adverse events were due to IV administration of epinephrine and occurred in adults. And you should know that EpiPen works through close. Delaying EpiPen increases risk for biphasic reactions. And the best way to alleviate safety concerns associated with accidental injections is through teaching and learning proper administration techniques. Here is a slide for more information to learn about anaphylaxis and its treatment.